Now Dr. Smitha will be talking on NTG, how the CNTGS results have influenced my treatment.
Good morning. My topic is NTG, how the CNTGS results have influenced my treatment. In normal tension glaucoma, the IOP is less than 21 millimeter mercury with a glaucomatous optic nerve damage, visual field changes, and an open angle on gonioscopy. NTG and POIG represent a continuum of open angle glaucoma, where IOP is the predominant risk factor in POIG, while IOP independent factors play a role in normal tension glaucoma. The clinical findings in normal tension glaucoma are focal rim loss, focal RNFL defect, visual field loss close to fixation, and increased prevalence of disc hemorrhage, peripapillary atrophy, and acute pit. So, if the IOP is normal in normal tension glaucoma, whether there is any role for further decreasing the IOP, the question is answered by the collaborative normal tension glaucoma study, which was conducted in 1998. The patients were randomized to treatment group and non-treatment group. Those in treatment group, the IOP was reduced to 30%. The randomization was done when they met the criteria for the diagnosis of normal tension glaucoma, when they showed documented progression in the disc or field, and when there is high risk field defects that threaten fixation and the appearance of disc hemorrhage. 230 patients were enrolled in the study. The inclusion criteria include unilateral or bilateral NTG with visual field defect, optic disc abnormality, IOP less than 24 millimeter mercury. Ages, they included 20 to 90 years of age, and 10 baseline IOPs were recorded after 4 weeks washout period of drugs. The median of the 10 readings should be less than 20 millimeter mercury, and no readings above 24 millimeter mercury, and no more than one reading of 23 or 24 millimeter mercury. 3 good baseline visual fields were done. And those who are randomized to treatment, they undergo 30% IOP reduction with drugs or organ laser trabeculoplasty, and 20% IOP reduction with filtration surgery. Beta blockers and alpha agonists are not used, and the goal was to reduce the IOP by 30% in 6 months. The endpoint is the occurrence of visual field progression, change in the degree of disc damage, or both. And 140 eyes of 140 patients were used in the study, with 61 in the treatment group and 79 in the untreated controls. The mean IOP in the treatment group was 10.6 millimeter, and untreated group it was 16 millimeter. 35% of the controlled eyes progressed, while only 12% of the treated eyes progressed. Of the 34 cataracts developed, 23 developed in the treated group, with the highest incidence in those whose treatment included filtration surgery. So those who are not treated, 1/3 showed progression in 3 years, and half showed progression in 5 to 7 years. And the risk factors for progression are females, migraine, and disc hemorrhage. The limitation of the study is in CNTGS, IOP more than 21 millimeter were included, and the upper limit of IOP criteria was 24 millimeter mercury, that is higher than the conventional NTG criteria, and the central corneal thickness was not measured. And optic disc hemorrhage was used as a sign of progression for randomization into the study, and not as an outcome measure of progression. And intent to treat analysis affected by the coincident cataract formation. It performed TRAB in half of the patients in the treatment group to reduce the IOP, which could induce cataract and mask the beneficial effect of IOP lowering treatment. It did not evaluate the possible beneficial effect of IOP lowering treatment when the percentage of IOP lowering did not exceed 30%. In conclusion, slower rate of visual field losses in cases 30% or more lowering of IOP, and the rate of progression without treatment is highly variable. Half of the patients have no progression in 5 years. A faster rate of progression occurred in females, patients with migraine, headache, and disc hemorrhages. So treatment should be individualized according to the stage of the disease and rate of progression. Another relevant study in NTG is the low pressure glaucoma treatment study, where it compared the use of timolol with brimonidine, and after 3 years follow-up, visual field worsening was more likely with timolol than brimonidine, and the IOP lowering effect is similar, but there was high rate of brimonidine intolerance, and 28.3 patients discontinued medication. So if the IOP is stable and still the disease progress, then you have to take 24-hour IOP measurement and see. If it is still under control, then you have to take a detailed history. And NTG is a multifactorial disease. Cardiovascular system plays an important role, and all this nocturnal hypotension, autonomic dysfunction, intracranial pressure, and obstructive sleep apnea have a role. There is if the ocular perfusion pressure is decreased, there is decreased blood supply to the optic nerve fiber, and it can lead to NTG. Vascular dysregulation has also an important role, and if there is vasospasm and endothelial dysfunction, all these lead to autoregulatory dysfunction, which leads to decreased ocular perfusion pressure and can lead to NTG. In obstructive sleep apnea, there is recurrent, complete or partial interruption of the normal breathing, and it results in decreased arterial oxygen and rise in carbon dioxide saturation, and results in decreased ocular perfusion and leads to glaucomatous optic neuropathy. So, neuroimaging is indicated in cases of young individuals, new onset or severe headache, when there is neuroretinal pallor, highly asymmetric cupping, there is lack of disc field correlation and visual field defect respecting the vertical meridian, and when there is sudden or rapid glaucoma progression. The take-home message is NTG is a diagnosis of exclusion. Detailed systemic history and evaluation should be done. Controlling IOP remains the mainstay of treatment. And in NTG, if it is progressing, you have to rule out other vascular and systemic factors. And all the cases don't progress, and such cases can be left untreated. Patients should be informed about the importance of follow-up, and communication is the key. Thank you.